Thanks very much for coming to this session, which is really quite a broad session looking at some of the research that we do in the Policy Research Unit. And the way we're going to do it is we'll have, in the first half, presentations on 4 varied PRU projects that are either completed or undergo. And then after the break, we'll broaden it out with a panel discussion about the general question of, well, what is policy research anyway, and how do you do it well? So hopefully the 2 bits will cohere nicely. How we're going to work this first half, if we can, is to have 10-minute presentations and then 5 minutes for question and answer directly after each presentation. So then we'll have a quick break and come back after that for the panel discussion. So if we can be disciplined about time and I stop talking now, that should work well. So I'm going to let our presenters, they can introduce themselves, but the first project up is talking about mental health care and mental health needs during the pandemic. And Nafisa and Anna, please come and do that. Thank you.
Hello, everyone. I'm Nafisa. I'm a research fellow here at UCL. Thank you for attending this session today. My colleague Anna and I are going to talk about a systematic review about mental health needs, mental health in Europe in COVID-19 pandemic. It was a systematic review that a large team of us carried out here at the PRU, including lived experience researchers and epidemiological experts. We were asked to conduct a review on mental health needs following COVID for Department of Health analysts to inform forecasting. We focused on European high-income countries to reduce the variation in pandemic waves and country responses. Our research questions were both before versus after and during. How did incidence or prevalence of mental health conditions change? How did symptoms, social measures, and suicidal behaviours change for people with pre-existing mental health conditions? And what changes have there been to mental health service use? We searched for electronic databases and preprint servers in February 2022 for primary research relating to mental health and COVID-19. This is some of the few terms that we used. Here is our eligibility criteria, and depending on the research question, it was either general population or people with pre-existing mental health conditions that we were looking at. We included studies that looked at either before and after or over the course of the pandemic, and we included longitudinal and repeated cross-sectional designs. This rather detailed slide here is our study characteristics. I'll leave it here for you to look at, but as you can see, we assessed quality on the Newcastle-Ottawa scale, and the majority of the studies rated highly in terms of quality. We also assessed the strength of evidence using the grade system and the distributions there. So 177 studies were included, and this reported studies on 180 records. So the first research question focused on change in prevalence and incidence of mental health conditions. And for the studies that looked at both before and after the pandemic, there was evidence of high to moderate certainty that the prevalence of depression and anxiety was higher at the onset of the pandemic compared to before. There was some very low certainty of evidence that eating disorders may have also increased during this time. However, evidence was lacking for other major conditions, including psychosis, bipolar, and personality disorder. For studies that looked at changes during the pandemic, the evidence was quite mixed. So there was evidence of moderate certainty that prevalence of some mental health problems may have reduced, for example, depression and PTSD. But there was indication that others increased, so anxiety may have increased, so where you can see later 2021. And there was some evidence of no change for others, so depression in the first half. Only a few records looked at changes in incidence, and they used healthcare records, and they consistently reported fewer incident diagnoses following the onset of the pandemic than pre-pandemic. And this corresponds with the reduction in service use that my colleague Anna will present shortly. So research 2 examined changes in outcomes for people with pre-existing mental health conditions. And overall, there was no striking changes. Most studies reported no significant change or different findings for different outcomes. We've tried to pull out some of the outcomes for this question where there was some change, but evidence was generally of low certainty across outcomes, and this was partly due to the few contributing studies per outcome. So this question had the least amount of contributing studies compared to the other 2 questions. So there was evidence of very low certainty of worsening symptoms for children and young people with some conditions, including depression and anxiety, some indication of worsening in social functioning, improvement in psychosocial outcomes, and then there was mixed findings for suicidal behavior. So self-reported suicidal ideation in adults increased, but self-reported self-harm decreased over 2020. So for the next part of the presentation, my colleague Anna will present. Thank you.
Hi everyone. So I looked at the 3rd research question, which looked at what changes have there been to mental health service use. This research question actually had quite high certainty for outcomes compared to the previous one. So yeah, our outcomes were high to moderate certainty for mostly, apart from some of the conclusions about the later dates in the pandemic, because we had a lot less data and fewer papers about what happened as the pandemic progressed. But quite unsurprisingly, at the start of the pandemic, service use decreased significantly in many areas, if not most areas. They're listed here: acute mental health care, community mental health care, primary care. Apart from, there were some exceptions in trauma and resuscitation units actually had increased admissions after that initial onset. However, in these 2 areas, the certainty was lower for the trauma and resus units. As the pandemic progressed, these decreases below pre-pandemic levels of service use persisted in many areas, but not all areas. So community mental health services for adults of working age actually had increased use at later time points, increased above pre-pandemic levels. So as in the other 2 research questions, we also looked at how service use fluctuated over the course of the pandemic. And after that initial decrease at the onset of the pandemic, service use started to increase in most service areas. And later in 2021, this has still increased. This increase continued, but actually stayed below pre-pandemic levels in a lot of areas, but not all. For example, that community mental health services for adults that I mentioned in the previous slide. But as this session is about policy relevance, we just wanted to focus on that for the last 2 slides. So yeah, this research was relevant to policy. It was commissioned by policymakers, and our conclusions directly pertained to some of these important questions. So we did find evidence of the impact of the pandemic on mental health, symptom services, and prevalence, but it wasn't quite that second pandemic that a lot of people had predicted. We didn't see that second pandemic in mental ill health. However, we did see suggestion of this widening of an existing treatment gap that we know is there. So because of at the beginning of the pandemic, we saw an increase in prevalence of mental illness, but a decrease in service use that hints that, this pre-existing treatment gap may have widened. We kept our research policy relevant by having interim meetings with policymakers. We presented the UK results halfway through the research project, and at this point, policymakers kind of guided our questions and suggested we perform certain subgroup analyses, which we did, especially for the prevalence question. We think our research is directly relevant, especially for preparing for future crises. We show that the societal factors already at play may really matter. So this existing unmet need that was present at the start of the pandemic seems to have been exaggerated, at least at the start of the pandemic. But as I've said, most of our data concerned earlier time points, so we really need to keep on looking at the data to see how that that existing treatment gap between service provision and service demand may have impacted mental health long term. And we came across a few challenges. The trade-off between the speed of which we needed to conduct the review to keep it relevant for policy, but also this came at a cost of the types of questions we could answer and the extent of our subgroup analyses. And we didn't perform, for example, analyses based on different countries in Europe, which would have been interesting, although the data also wasn't actually that thorough to be able to do that. Notably, there was a massive lack of co-production in the studies included. I'll go on to talk about that more with regard to our lived experience commentary. But very few of the studies we included had any co-production involved. There was also some weakness in the evidence. We had quite crude measures of depression and anxiety rather than more complicated clinical measures. And yeah, the real main thing that these challenges highlighted was that we need a really more coordinated response in future. So a lot of studies were just replicating the same questions. So how did prevalence change in the pandemic, rather than actually focusing on really important questions such as the impact of the pandemic on vulnerable groups. For example, people with severe mental illness, we had very little data on those important subgroup analyses. So finally, as with most of the papers at Peru, we included our lived experience research colleagues included a lived experience commentary in the paper, which was published within the paper in the Lancet Psychiatry. Please read the full lived experience commentary online, but here are some key points that they covered. Again, this idea that only 4 studies were included co-production at all. The studies, we know that changes happened, but we don't know why they happened, so we need kind of more qualitative data there, and we need to know about the trajectory of people who could not access those statutory services during the pandemic. What was their experience and what happened there? I think I'm out of time, so any questions?
Thanks, Nafisa and Anna, that's fantastic. So I think we've just got time for 1 or 2 brief questions or reflections if anybody has any from the audience they'd like to ask. Steve.
It's been there in the detail of your report, but I wasn't just clear whether the subsequent increase, which we've seen in other data we looked at, was an increase over pre-pandemic or an increase on the lower levels of the pandemic. I think it's the former, but I wasn't quite sure.
Good question. It varied depending on the service area we were looking at, but the increase above pre-pandemic levels was particularly noticeable with high certainty evidence for community mental health care for adults. So that increased above pre-pandemic levels.
Okay, Raza.
I was wondering if you could just say something about what the impact might have been on the way the research was conducted, because in a sense it was being done almost in real time with, the Department of Health would have wanted results and information as quickly as possible.
Yeah, that was one of the biggest challenges that we had, that we needed to get the review out quite rapidly. So we did an extensive search and we identified a lot of records, but it meant that there were some things that we couldn't look at more in depth, things like cross-country comparisons, but we've made suggestions for future research for that.
Okay, thank you very much. I think in the interest of time, we better move along, but thanks ever so much. And if any of you have questions which you don't have time to ask in this, just feel free to buttonhole presenters in the break or bring them after the break for the panel discussion as well. But we're going to do a quick move on now away from COVID and epidemiology to social interventions in mental health, and Phoebe and Becky are going to talk next.
Hi everyone, so can everyone hear me okay? Yeah. I'm Phoebe, I'm also one of the researchers for the PRU. So I'm going to talk to you a little bit about, firstly, a review we did of randomized controlled trials looking at social interventions to support people in the community And then we're going to talk a bit later also about further work we did moving on from that to try and categorise these interventions more broadly. So the reason we did this was because the Department of Health and Social Care, they were really keen to look at some useful social interventions for people to improve the outcomes for people with severe mental illness and delivery of the NHS long-term plan. So we were commissioned to look at potential models that could be used and potential interventions. As a background to this work, as we know, people with serious mental health problems, they face social exclusion, they have poor social outcomes, poorer than the general population in a number of different areas. Examples are high rates of unemployment, poverty and debt. They're more likely to be a victim of crime, and they are more likely to end up in the prison system, and just generally a risk of being socially isolated as well. So based on all of this, we asked a number of key stakeholders in the area what were the main areas that we should look at in terms of social interventions. And these are the 8 areas that we came up with. They're definitely not exhaustive, but we felt that they were a good starting point in order to look at different interventions in so many different areas. So we conducted a review, and this is just the paper that we published as a result, and this was just looking at randomized control trials of interventions conducted in community settings. We didn't limit the population of this study to people with severe mental illness, but the majority of the interventions were conducted in that population, so there was much smaller scale of evidence for people with mental health disorders that aren't severe mental illness. And this is just a quick overview of the results we found of such a big review, but there were 2 main areas where we could find some really good evidence, and that was to support people with housing and homelessness. And this was the Housing First interventions. There's been a number of trials reported on this, so there was quite good evidence for that. And also for work and education, there was individual placement and support, which also had a number of different trials in a number of different countries actually looking at ways you can use individual placement and support and whether you can have add-on treatments with that and how that works. So overall, what we found was that high-intensity interventions which focus on the desired social outcome and provide comprehensive multidisciplinary support can influence positive change rather than interventions that may not be as focused on that social need. There was some evidence to suggest that we could support people with social isolation by using a range of approaches, such as social skills training and supported socialization. Interestingly, the research looking at reducing offending in people with mental health conditions was quite lacking, and that was because although we found a lot of evidence that was for people in the prison system, because we were looking at community interventions, there wasn't that much evidence. We also found limited to no evidence for helping people to maintain family, caring and intimate relationships, supporting people with money and basic needs, reducing victimization and exploitation, and rights, inclusion, and citizenship. So based on that, we kind of moved on to looking past the RCT evidence, and that's where I'm going to hand over to Becky.
Thank you. So I'm going to take you through the next stage in this research, which is where we built on the findings from the previous RCT systematic review to build a conceptual model to categorise these social interventions. With this research, we did just focus on adults with a serious mental health condition. By this, we just meant anybody whose mental illness is of a severity where they would normally require input from secondary mental health services. And the types of models of support we were looking for were any interventions or approaches which had some structure, so they could be replicated, they involved some sort of training or induction or specific prior expertise. we also needed the direct focus of the intervention to be on improving somebody's social circumstances. So, for example, anything identified in the 8 previous domains. We did a scoping review of existing literature. This was both published and grey literature, and also did some expert consultation. We were really keen that we didn't want to miss any literature just because it wasn't published in an academic journal, so we did have quite a wide kind of search approach for this. And we also conducted some stakeholder workshops where experts could come and feedback on the approaches that we'd identified and perhaps bring any other evidence that they were aware of which could support the use of these approaches. Through these workshops, we then developed the conceptual model of social intervention approaches, and this was done in an iterative process, and we went through several different versions of this model in collaboration with our lived experience working group. We ended up including 143 publications or written descriptions, providing evidence on 80 models, and we also found a further 12 models from responses to the expert consultation, and also the models with high levels of evidence identified in the previous review, so things like Housing First or IPS, which gave us a total of 92 models. And this is the conceptual model which we developed. So we distinguished 5 different sources of support, so mental health care and social care practitioners, social domain topic experts, peer workers, structural forms of help or citizens and the wider community, and also 5 different types of support. So information and signposting, providing care and assistance, direct provision of money or resources, additional rights or entitlement to support, and also social support. In this figure, these are shown along with the proposed broad mechanisms by which they may improve the social circumstances of people living with serious mental health conditions. And we use these categories to describe all of the models we'd identified during our searches. And just to give you an example, one of the sources of support which we found was mental health breathing space, which is an intervention which aims to provide short-term respite from debt for people with mental health problems. So this involves structural help in the form of a legal right to a break from creditors enforcing debts or payment charges, which allows that person to focus on their mental health recovery. They are provided with advice from a social domain topic expert, so in this case from money and debt advisors. And the types of support they're given are information and signposting to resources, providing care and assistance and developing strategies to manage their debt, and also additional rights or entitlements, as they do have that legal break from creditors pursuing them for their debt. And so the implications of this work, we did identify so many models which lacked a kind of real rigorous published description or evaluation. However, this doesn't mean that they might not be valuable, and they still work really well for that specific context. And this lack of evidence about effectiveness is a barrier to further funding and perhaps broadening the reach of these models into other areas of the country. And given this current state of knowledge, service evaluation in practice context is particularly useful and could be something that could be expanded on moving forwards. We do need to establish these effective models without constraining them, so whilst they can be broadened out to increase their reach, it's still really important that that flexibility is in there to help meet the needs of the local population. And our conceptual framework could be used perhaps in other research to help describe models and inform evaluation of different approaches. Here are some reflections kindly provided by our lived experience working group. And here are just some of the ways that the lived experience group contributed to this project. So firstly, giving perspective on how these different domains interact and what interventions could be categorized into these different domains. And also ensure that the language we used was appropriate and non-stigmatizing. They also reminded us of the importance of choice and agency in interventions. And there are a couple of quotes here which I think illustrate this point really well. There was one other interlinked piece of work we did, which looked at the psychological impact of the benefit system and how any harms might be mitigated. This fed into cross-governmental mental health strategy and was also shared with the Parliamentary Work and Pensions Select Committee. So this was just one way that we're really hoping to have some policy impact from this work. And finally, we also tried to engage policymakers as much as we could in this research. It was originally designed to inform the government's suicide prevention strategy and also to inform the mental health strategy, which was unfortunately a victim of the reorganisation within the Department of Health. And so this work is now being integrated into a major condition strategy, which we hope is planned for some time this year. We have also conducted a policy briefing in collaboration with the Centre for Mental Health as another way to try and get more policy impact from these findings. Just a few references, and big thank you to all of the authors of this research.
Thank you, Becky and Phoebe. So time for a few questions from the audience, if anybody has them again, and I'll bring the mic round. So just stick your hand up if you have any. Okay. Steve, go for it. Yeah, thank you.
There's an awful lot there, which I just about kept up with. But which of them, I'm thinking of my policy chat a bit later on, if you had to pick one of them that you thought would make the biggest change in people's lives, which one would it be?
I think the trouble with this, and it's a little bit similar to what Becky alluded to earlier, is there were a lot of descriptions of models that we found that have clearly made a big impact on a small scale, and it's hard to know to what extent they would make the same impact if they were scaled up. Often things make such a big impact because they work really well within the context they're in. So on that basis, it's a really hard question to answer. On the basis of the review of RCTs we did, I think it's really clear that IPS has made a massive difference to a lot of people and is really beneficial, but I don't know whether there are other interventions to support people with their employment that might be better. They just haven't been evaluated to the same extent. So, yeah.
Yeah, I'd just add to that the work that Becky talked about last, about the benefits system and social security policy. There's just quite a lot of international evidence, really, that the more fitness for work tests you do and the more stringent they are, the more you sanction people and the lower level of benefits are, is bad for the nation's mental health, really, that increases depression and anxiety and suicide rates. And that's just a sort of really big thing, isn't it, that affects large groups of people. So, yeah. Helen, hi.
Thanks very much. It's a related point about the evidence for housing first. When you get a model which people can relate to and they evaluate it repeatedly in different settings, obviously the evidence base builds. But one of the biggest problems with the evidence for housing first is that the outcome is usually getting homeless people into stable housing. So it's a bit kind of obvious. You take someone who hasn't got a house and you give them a house, they get stable housing. So the benefits of housing first are often somewhat overstated by rather blunt outcomes. And I wondered, it's difficult when you're investigating social interventions to get good outcomes that you can actually measure, so you can see why people do that. But I wondered how you could reflect on that in relation to the other interventions and whether there were similar problems in thinking about how you collate the evidence up. So it's a very long-winded question.
Definitely. I think it was really challenging. I think because, like I say, a lot of the evidence of the models that we included, that it was mainly just because someone had kind of told us about them and they seemed good, or that there was a really a great report which had written about it, but it didn't mean that it had been robustly evaluated. And I think there was something really important about actually pinning down what we're trying to change in terms of these interventions. I mean, it could there's also, they're all kind of quite interlinked, so it could be that improving someone's housing then improves their chances of finding a job or improving their mental health as well. So I think that is definitely one challenge which should be looked at in further research.
Okay, we have one question from Zoom and just time for one more, I think.
The question goes, does the cancellation of the government's commitment to mental health strategy suggest the research was less than compelling for policymakers? And if so, why?
Tricky. I think it's a shame, really, because we did have quite a lot of really positive meetings with representatives from the Department of Health during the course of the second phase of this work. We presented it a number of times before we kind of reached the final report. I think it's just a change of priorities that came from the top, and I don't think the people we spoke to particularly had any choice about that. I'm not sure there's anything else either of you would like to add.
Yeah, No, I mean, I think like Sonia was saying right at the beginning of the day, research is just one element, isn't it, that feeds into policy decision making, and I think it absolutely wasn't that they were hanging on our research and when they didn't like it, they cancelled the programme, really. That's, we don't have that much impact at the best of times, really, but yeah. Okay, thank you. I think in interest of time, we better move on, but thank you very much, Becky and Phoebe. So the next project we're going to talk about is an ongoing piece of work, and Sharon's going to talk about the economic costs of loneliness.
Okay, thank you, Bryn. So my name is Sharon, and I'm a research assistant working in the Peru, and I'm currently working on this project, which is all about the economic cost of loneliness. So just briefly, a little bit of background first. So loneliness is a subjective state resulting from a discrepancy between someone's desired and achieved level of socialization. And it has been linked with a range of physical and mental health problems, including depression, anxiety, suicidality, cognitive decline, and general mortality. And interestingly, loneliness is associated with both the onset of mental health problems, but also may be a consequence of them. But despite these sort of general health implications, there's been relatively little research into the economic implications of loneliness, which may bring considerable costs to health and social care services. So Michalopoulos and colleagues attempted to sort of address this gap in 2020 when they conducted a systematic review looking at the economic costs of loneliness. And they looked at this in sort of two branches. So first of all, at the economic burden associated with loneliness and social isolation, and also looking at economic evaluations of interventions to reduce loneliness and social isolation. So they included articles from 2008 to 2018, which is when they conducted their search, and they found 12 studies in total, which were focused on loneliness and social isolation economics, and in general found that most studies reported excess healthcare costs associated with loneliness and social isolation, and that interventions generally provided good value for money when they were effective. However, there were some limitations of this review, and I think the authors highlighted that there wasn't very many studies conducted in this area, which meant that there was quite a lot of inconsistency across the studies they did include, which made comparisons across them quite difficult. They also excluded studies with mental health as a primary outcome, and excluded studies that reported service use but not cost, and they identified at least 7 of these through their searches. And all the studies that they included related to older adult populations. And I think it's also worth highlighting that a lot of loneliness research has been published since 2018. So if you have a look at the graph on the right there, you can see even in the last 5 years, there's been a massive increase in the amount of publications relating to loneliness. So we kind of built off this review and decided to conduct a systematic review on the economic costs associated with loneliness, and also to review economic evaluations of interventions to reduce loneliness as well. So we replicated the 2008 start point from the previous review and updated the timeline to 2023. We searched 5 primary databases and then 2 additional databases for grey literature. And we decided to include cost of illness studies and studies on loneliness and health and social care use, which is something that they didn't include in the previous review, and also economic evaluations of loneliness interventions. And we wanted to include studies that considered both mental and physical health outcomes, and also include all languages and all population groups. And we decided to exclude studies that primarily focused on related topics to loneliness. So we actually excluded studies related to social isolation primarily and social exclusion, which again is something that we did slightly differently to the previous review. And we also excluded studies that reported loneliness as a secondary outcome. and qualitative studies, reviews, and books as well. And this is just a brief overview of our search. So you can see there we had sort of two topics, one of which was very simply just loneliness, and then the other related to the various types of economic information that we were interested in. And we searched our 5 databases, and after deduplication, we had 982 papers left to screen. And this is kind of where we're up to at the moment. So we've double screened all 982 papers and double screened all of the full text papers as well. And at the moment, we have 23 papers for data extraction, which is the next stage of the review. So yeah, up next will be data extraction, where we'll be looking at information relating to both direct and indirect costs, as well as details of service use and details relating to intervention studies. And we also will be conducting quality and risk of bias assessments as well. And then after data extraction, we'll be synthesizing the data. Similarly to how they did it in the Mihalopoulos review, we'll be doing a narrative synthesis due to the variation of the studies that we've included. And we're hoping, if possible, to be able to compare subgroups according to potentially age and/or health status as well. But obviously this will depend on the studies that we have included. And this is just a slide that was prepared by Stephen Jeffries, who's working with us on the review. And he's just included some reflections from a lived experience perspective of working on this review. So he's highlighted that health economics research and evaluations are in demand by policymakers, and it's very important to have the lived experience and experiential lens in doing this research and on the methodologies adopted. So in our study, we have 4 LUG members who've been invited to the main project meetings, and then 2 members, including Stephen, who have been involved in working on the project doing screening, and also will be involved in the data extraction and quality appraisal. So Stephen has highlighted that we're a small but supportive team, and that academic staff are assisting in understanding the technicalities through explanations and contributing to a glossary of the technical terms involved. And that this project is a good example of the need for training and acquiring knowledge and experience of the differing types of research to facilitate best input on a more equal footing with the general research team. And I think this is something that I would echo, that the sort of economic side has definitely been a learning curve for everyone involved in the project. So that's been very interesting. And then just some broader context then, which is relevant for this review. So the review is kind of conducted in the context of the community mental health framework and also the wider policy interest in enhancing the social support available to people with mental health problems and long-term conditions in general as well. And this is to both help recovery and also to relieve pressures on the NHS. So our review is kind of aiming to add to that by quantifying the economic gains of helping with loneliness, which presented a challenge, I think, to our team, because it is a slightly broader question than we would typically tackle in the PRU, I think, but also highlights a benefit of PRUs, which is to address really important interdisciplinary research questions and to expand our reach and our relevance of the topics that we cover. And then just a word on making the review sort of as relevant as possible for policy. So we have numerous policymakers attending our monthly meetings, and particularly at the start, we were keen to have policy members attend to really direct and shape the review according to what they wanted it to look like. And one of the challenges that we sort of noted early on was how to really maintain the relevance for the NHS specifically. And this was one of the reasons that we decided to slightly widen the focus to include studies on service use, as well as studies that report direct costs, because we feel that this was a really relevant kind of topic to include for NHS. And we also narrowed the focus because of this, looking specifically at loneliness and not related concepts, because I think that the policy makers that we interacted with were quite clear that their interest was mainly in loneliness. And when the review is finished, we'll be developing a conceptual model to identify the key relationships between healthcare resource use and loneliness. And we're also in tandem identifying existing data sets that contain information on loneliness and economic consequences in the UK. So we're hoping to kind of highlight what might be useful to inform future policy-relevant quantitative research and modeling on this topic as well. So that's the end of my presentation. Thank you very much. And just to thank the rest of the team as well, who I've listed out here. Thank you.
Sharon, so we're on time, so we still have time for any questions people may have on this work. Hi.
Thank you for that. It's really interesting. There's so many things going on in my head that you've started to raise, and I wondered if we could tease out just a little bit. It is a really interesting topic, because I'm wondering if actually there's a question for the NHS, but for other sectors as well, as to who is responsible for loneliness, who is it impacting? And you had, for example, on your last slide, what's the relationship between healthcare use and loneliness? I'm assuming that's to kind of look at whether or not providing people with support makes a difference. But actually, I wonder if their question at heart is, does loneliness have an impact on healthcare use? Because until they know that, why would they fund a health I mean, it's a really, really interesting one, and it just, as you said, covers multiple sectors. So I don't know if you've got a sense of that while you were preparing for this, or any discussions you had. And just one final comment, the lived experience slide, absolutely agree. Explaining these things, I've seen it done so badly, and I've seen it done really, really well. My advice is to find somebody who does it really, really well, and to record a session. That helps, to just so that you can ensure that when you are communicating with those groups, that they do understand, because sometimes, like I said, I can see them just be put off. And frankly, it's not just lived experience, it's professionals as well who can be put off by not understanding what's been explained. So I think that's really important.
Thank you. So to kind of touch on your first point, I think it's a really important question, and I think one of the things that makes loneliness a really interesting area at the moment is this massive increase in the research that's being done, and also the interest in it. And I think the COVID pandemic obviously has a considerable role to play in that. And I think that kind of bidirectionality of loneliness with mental health is really interesting, because it sort of creates two potential avenues that you can approach it from. I think it is quite a transdiagnostic problem for people with mental health problems in general. So it's definitely worth considering how we can help with loneliness in people who have existing mental health problems, but also really interesting to look at it from, can we potentially target loneliness and reduce either the impact of mental health problems, or help, sort of moderate some of the negative impacts that future mental health problems might take on. And I think, that this sort of highlighted that it makes it a little bit challenging, I think, to do a review like this, and other research in loneliness that I've done. It's, I think, one of the most interesting aspects of it, but teasing out at what point you look at it and target it is can be quite difficult.
Okay, thank you, Sharon. I think we better move on to our last presentation before the break. Thank you very much. So, final one, Merla is going to talk to us about inequalities in access to psychological treatment for people with early psychosis.
Hi
Hi everyone, I'm Merle and I've worked as a research assistant for the PRU and I'm also a PhD student. Also, I tend to be not that great with microphones, so please wave at me if you can't hear me. So yes, as Bren mentioned, I'm gonna present the findings of our study on ethnic differences in receipt of psychological interventions in early intervention psychosis services in England. And the slides have been co-created with my colleague Patrick, who unfortunately can't be here with me today, but I will try to represent him as much as possible. So firstly, what do we know so far? So in general, there is evidence that there are ethnic differences in the psychosis care provision, and that also is the case for psychological interventions. So most minoritized ethnic groups tend to be less likely to receive psychological interventions for psychosis compared to white counterparts. And that's the case in the UK as well as in the US. So in the UK, one key setting for the delivery of psychological interventions are early intervention psychosis services, and that is especially for the people with a first episode of psychosis. And the NICE guidelines mandate that service users with a first episode of psychosis should receive 16 sessions of CBTP and 10 sessions of family intervention. So what do we not know? We don't know whether these differences in receipt of CBTP, so cognitive behavioral therapy for psychosis, and family intervention also exist in ERP services specifically, whether they exist across more fine-grained ethnic groups compared to previous research, used by previous research, and then also what the magnitude of such differences is. And therefore, our aims were to investigate ethnic inequalities in receipt of CBTP and family intervention in EIP services, and then also investigate the role of individual level and team level factors in this potential association. In terms of our methods, we use cross-sectional data from the National Clinical Audit of Psychosis, short NCAP, and we merged 3 years of data collection, so from 2018 to 2021, and this data was based on questionnaires that were completed by all EIP teams across England. And so EIP teams then provided information on a sample up to 100 service users for each EIP service team, and that left us with a total sample of 29,610 service users, aged between 60 and 65. In regards to our variables, so we looked at receipt of CBTP and family intervention, as mentioned before. We looked at 17 different ethnic categories, and then also at the following individual level and team level covariates or confounders, being age, gender, occupational status, as well as the staff caseload of a team, and whether a trust had a strategy to address inequalities in mental health services in place. And then for the analysis, we used multi-level logistic regression analysis. So in terms of the results, a little sneak peek. But firstly, to the sample characteristics. So you can see here the breakdown of the different ethnic categories, the biggest group being the white British group, followed by 6% for the white other Black African group, as well as mixed Black African white and mixed Asian white group. The white Irish and Chinese group were quite small, as you can see. It wasn't 0.00%, so there were some people. So most people, service users, were male. They were younger than 35 years old and out of work, education, and training. In regards to the proportion of service users who received psychological interventions, so this is the NTI sample, only 47% received CBTP and 19% received family intervention. Here you can see the results of the main analysis for CBTP. The bar graph represents all the different ethnic categories. The red dotted line is the white British reference group, and as you can see here, 14 out of 60 minorities ethnic groups had lower odds of receiving CBTP compared to the white British group. So only the Black African white and Asian white service users, mixed Asian white service users, show to have no differences in odds compared to the white British group. As you can see with the overlapping confidence intervals. And then the group with the lowest odds ratio were the Bangladeshi service users, so they experienced a reduction of 61% in odds of receiving CBTP. In terms of family intervention, 7 out of 16 minoritist ethnic groups had lower odds of receiving family intervention, and that included the white other group, the black African group, the black Caribbean group, the black other group, and then also 3 more less clear ethnic categories. And the lowest odds were among the black African service users. In terms of individual and service level factors, women had higher odds of receiving both interventions compared to men. Older service users had lower odds of receiving both interventions compared to the younger service users, and then service users who were out of work or education had lower odds of receiving both interventions compared to those who were in work or education. In terms of the service level factors, we found that service users who attended ERP teams within trust with their inequality strategies had higher odds of receiving CBTP. We didn't find any difference for family intervention or for staff caseload in the adjusted model. Moving on to a few points in regards to the limitations. So firstly, the effect sizes might be biased due to a potential sample overlap, and that means that some service users might have been included in multiple of the waves, so in each of the different years, which might affect the accuracy of the effect sizes, but we tested for that in the sensitivity analysis, and that actually doesn't seem to be the case. Then, as I mentioned before, the outcomes and exposures are based on clinician reports, and therefore that might affect the accuracy and validity of the recordings, especially in terms of the receipt of interventions and ethnicity. However, ethnicity should be based on self-report in general, but that isn't always the case. And lastly, we weren't able to include all of the covariates we would have liked to include due to general data issues. Moving on to some lived experience researcher reflections. So we involved 3 lived experience researchers from different ethnic backgrounds who attended meetings and advised on the methods and the interpretation of the roles, and therefore provide really crucial input to the paper, especially in terms of the interpretation. These are some reflections from Patrick, who, again, I try to represent here. He pointed out that, in general, most minoritized ethnic groups do value family involvement in their care. So the finding of inequalities in family intervention does raise the question around the appropriateness of westernized commissioning, design, and implementation of family interventions in ERP services in England. And so we need more research on the implementation and effectiveness of CBT and family intervention at a system level, across services and at different pathways, focusing on the experiences of minoritized ethnic groups. And importantly, we also need more research, particularly qualitative research, on the underlying causes of the ethnic inequalities we observed in regards to receipt of interventions, particularly focusing on the role of discrimination, stigma, and cultural barriers on all the different levels, so individual, social, and structural, and service levels. A few policy reflections, and I group this into project facilitators and project barriers that made our project more relevant, or the challenges and the challenges we experienced. So generally, being able to use this data was really helpful because we were able to look at all the ERP teams across England, and we were able to look at these very fine-grained ethnic groups which is usually not done in previous research, as well as a couple of service level factors. And then we also presented these findings to representatives from the NCAP project team, NHS England, and the HQIP project team. Again, the involvement of lived experience researchers from different backgrounds, and as well as representatives of the NCAP project team itself, was really helpful in shaping the focus of the project. However, we did experience some barriers and challenges, including massive delays in terms of the data access, despite the policy relevance of this project and involving, again, representatives of the NCAP project team. And we also experienced some challenges in regards to linking teams to trusts and then trusts to geographical areas, which meant that we weren't able to look at things we would have liked to look at, as mentioned before. So overall, we can conclude that our study provides strong evidence for ethnic inequalities in regards to the offer and receipt of psychological interventions in EAP services across England. And our findings have implications for policy and research, including that potentially mandating inequality strategies as part of routine EIP care might address some of these inequalities. However, we do need more research on the specific type of strategies, as well as the effectiveness and implementation of those, and again, research on the underlying causes of these inequalities that we observed to inform policy action. Massive thank you for listening, and also to the co-authors, particularly Patrick, for co-creating the slides. You can find our preprint online. That's it.
Thank you, Mela. That's great. And we've got time for 1 or 2 questions if people have them before the break. Yeah, I tell you what, I'll come back to you, Steve, in a minute. I'll just go over here and yeah, thank you.
Thank you. Very, very interesting presentation. At the last slide, you said a disparity in people offered and then received. But in the previous slide, you said received. So could you just give a breakdown? Were people not offered it as much, or were they offered it and then didn't take it up as much?
Yes. So when I said it, I noticed that I hadn't mentioned it. So I focused on our main analysis, which was on receipt and which I was talking about during the rest of the presentation, but we then also looked at differences in terms of offer and found that it looked quite similar to the receipt. So two differences in receipt in terms of the ethnic groups affected. It wasn't a complete same picture, but looked very similar, yeah.
Okay, I think we do have time for you, Steve.
By way of reassurance, and that should be in inverted commas there, the data you've got there very much mirrors the data from the IAPT NHS talking therapies from, particularly with the very poor outcomes for people from the Bangladeshi community. What we've done there is just taken it a little bit further than maybe you were able to, but you find a lot of correlations with the time that people wait to get into treatment, after they get into treatment, the time they wait for assessment. And actually, if you try and take those out, then some of those differences disappear. So what we said at a policy level is that engaging with local communities, for example, the Bangladeshi community, is probably a way forward. And if you look across the country where there are services that have done that, you get much improved outcomes for the Bangladesh one. Still not as good, but much improved. So it's rather nice, not quite the right word again, to see that, because it very much mirrors what's happened with common mental disorders. Final point, and actually we've also looked at this issue of culturally adapted, culturally specific, culturally sensitive treatment. And some work we've recently done with the Chinese data sets, I'm not convinced that that's a major issue. I think it's engaging with communities and getting people early into treatment is probably something we should be focusing on. But yeah, very nice to see.
Thanks. Any other? No?
Yeah.
Thank you.
Okay. All right, in which case I think thank you very much. Yeah.